Good morning everyone, and welcome to this Insight webinar. I'm Professor Leanne Hydes from the University of Queensland and the Queensland representative for APSAD. First of all, I'd like to acknowledge the traditional custodians of the land in which we meet today and pay respect to elders past, present and emerging. And we also extend our respect to other Aboriginal and Torres Strait Islanders who are joining us here today and online. Today it's my great pleasure to introduce Associate Professor Victoria Manning from the Addiction Studies Centre at Monash University, and she's also the Head of Research and Workforce Development at Turning Point in Melbourne. This is a great opportunity and a great partnership that we have with Insight and Queensland Health and APSAD, where we bring national speakers to Queensland so they can present for our audience, and nationally to members for APSAD. And so Victoria is going to be presenting today on her patient pathway studies, which was a massive study on 800 patients attending drug and alcohol services in Victoria and WA. So we're going to get some great insights today about what evidence-based practice is in our field and how we can influence policy and practice using that information. So please join me in welcoming Victoria.
Thanks, Leanne, and also thanks to APSAD for the invitation to be here to present and share the findings of this study. And good morning, everyone, and thank you for coming. So you'll see that I have deviated slightly from the title because really the patient pathway study really tells us more about how the treatment system can be configured rather than specific sort of interventions per se in terms of evidence-based practice. And some of you may be aware of the patient pathways findings, but really what I'm hoping to do today is sort of give an overview of those findings that have really advanced our understanding of effective care. And whilst we're really talking about contribution rather than attribution, I'll demonstrate how some of the findings have been used in government inquiries, reports and submissions and have potentially informed decision making around service expansion and system innovation, at least in the Victorian context. So Patient Pathways was a large 3-year multi-method study. So there was a review of the AOD treatment system. There was a client cohort that we followed up for 1 year to look at treatment outcomes. We also undertook some qualitative interviews with clients in that client cohort. And there was also a data linkage component where essentially we were looking to see using ADIS and data linkage acute health service use in the year before a client engaged in the AOD treatment system in the year after. So it was a collaboration between researchers at Curtin University, at the National Drug Research Institute in WA, and Turning Point in Monash. And the lead investigators were Dr. Linda Berens, Professor Robin Room, Professor Steve Alsop, Professor Dan Lubman and David Best, and a whole host of researchers, which I'll show you at the end. And so essentially today I'll be presenting on the outcomes, the pathways of care and related outcomes of the clients. Some of these findings were published in the Australia and New Zealand Journal of Psychiatry last year, and some of them will hopefully, that have not been yet published, will be out soon. So I guess why did we do the study? At the time when the researchers were designing the study, the most common reason for presenting to treatment was for an alcohol problem. So that represented about 45% of all presentations, and that was followed by cannabis, which accounted for around 25%. But you can see towards the end, at the right of that figure, there was an increasing trend in terms of presentations for amphetamines and a decline in presentations for heroin. And we saw a pretty consistent picture across the different states and territories, with primarily alcohol, cannabis, then amphetamines, and then heroin. But there were 1 or 2 exceptions. So you can see that in Tasmania, so if the pointer's working here, where is it? Green button? Where's the green button? Oh, red. Yeah, so in Tasmania you can see cannabis was very high in terms of presentations and very little heroin. And in the Northern Territories, much higher presentation of alcohol and very few illicit drugs in comparison, but in particular heroin. But at the time, so alcohol and cannabis were the most common reasons for presenting to treatment, and we had 2 major multi-site large treatment outcome studies. And these were looking at clients seeking treatment for heroin problems, and another one where clients were seeking treatment for methamphetamine problems. So the first was the ATOS, the Australian Treatment Outcomes Study. So this was conducted by Marie Thiessen and colleagues and was conducted with 745 clients who were seeking treatment for heroin, recruited from 38 agencies in Sydney, Melbourne and Adelaide. So this study recruited clients attending opiate substitution treatment, resi rehab or detox, and they also had 80 clients who were not in treatment but were recruited primarily from needle and syringe programs. So this study looked at outcomes at 3 months, 12 months, 24, 36, and about 3 years ago, they actually managed to do an 11-year follow-up. And they found that the average number of treatment presentations in that initial year was 2, that heroin use reduced from 99 to 41% in that first year. They found that the continuous abstinence rate of heroin was 14%, and alongside those substance use reductions, they also observed reductions in criminal involvement, injecting-related health problems, and improved physical and mental health. And the authors also found that the positive outcomes that were seen tended to be associated with those who had higher cumulative treatment days. In other words, it could suggest a treatment dose, because it was also associated with fewer treatment episodes. So it wasn't that people were disengaging and then re-engaging, because that would constitute as a new treatment episode, which really suggests that it's about treatment stability. The authors observed substantial and sustained reductions in heroin use across follow-ups. So at 11 years, 75% of the sample were no longer using heroin, and they were also saw major reductions in drug use, criminality and injecting behaviour. The second study is MATES, the methamphetamine treatment evaluation study. And this study looked at outcomes at 3 months, 1 year and 3 years. So this was undertaken by Rebecca McKeaton and colleagues. So they looked at 360 people who were dependent on methamphetamines, recruited from AOD services in Sydney and Brisbane, so resi rehab, detox, and they also had a control group recruited from community health services. They found that detox alone did not reduce methamphetamine use. Resi rehab, though, did reduce substance use or reduce methamphetamine use, but those reductions were generally short-lived, but they were at least observed at 3 months. And the rates of continuous abstinence were 33% at 3 months, 14% at 1 year, but only 6% at 3 years. And but a significant proportion were no longer meeting criteria for methamphetamine dependence. So 60% at 3 months, and 42% and 41% at 1 and 3 years, respectively. And again, we see reductions in drug-related harms. So really, the motivation behind the patient pathway study was recognising that we don't know very much about the outcomes of alcohol and cannabis clients who at the time were the most common presentations, and also recognising that we really need to know about the outcomes of real-world clients and not just those who meet the very strict inclusion and exclusion criteria of clinical trials. And we really need to understand about the dynamics of treatment by taking these sort of multi-site, large prospective treatment outcome studies. And a lot of the research prior to this had been conducted in the US and some in the UK, and tended to focus on single discrete episodes of treatment. So maybe looking at the impact of an episode of inpatient withdrawal, which is often just one component or one part of the AOD treatment journey. And of course, the AOD treatment itself is merely one component of a much larger interconnected system of general health, mental health, social and welfare services. So it was really sort of recognising that our understanding of service integration, integrated care is pretty poor, but even poorer is our understanding of how that impacts on treatment outcomes. And as Tom Baber noted in 2010, the cumulative impact of engaging with AOD services and non-specialist AOD services in the community should translate into population health benefits such as reduced mortality, morbidity, disability, suicide, crime, unemployment and healthcare costs. So what exactly do we mean by integrated care? But just for fun, I thought I'd share with you this definition. It's a rather cynical definition I found, and there's a few Brits in the room, so you'll appreciate this. He defined it as the unicorn of service provision, often spoken of but rarely seen. Some say they've seen it in Birmingham. Others say it's a mirage glimpsed by the desperate. Now, this is actually a really funny article. I recommend it. It was in the British Journal of Psychiatry, and Philip Timms is a psychiatrist at King's College London, and he essentially compiled what he called the Devil's Dictionary of all the jargon that we use in mental health that we're all guilty of. and really it's just a call for us to talk and write more clearly and to try and avoid these terms. But this is I guess an unreliable definition, because this is his definition of research. The selection of an unrepresentative group of people, the provision of an unsustainable intervention, and the careful selection of a rating cut-off point to show your intervention to its best advantage. So patient pathways is very representative. So so moving on, a more accurate definition is that it's really recognising that integrated care, it's at a systems level. It's dependent on funding, administration, organisational input and service delivery. But we're really talking about creating connectivity and alignment and collaboration between the sectors, between the treatment and care sectors, with the goal being to enhance quality of care and quality of life, consumer satisfaction and system efficiency for patients with these long and complex problems. Or more simply, a means of delivering health and social care services by coordinating the efforts of services who would otherwise be acting as single entities or units. So really we're talking about vertical integration within the AOD treatment system. So within specialist AOD care, this is essentially a stepped care model, so drawing heavily on the healthcare literature where the intensity of treatment that somebody gets is matched to their level of need and how they respond to different treatment modalities. So for example, you may start somebody who's meeting criteria for alcohol dependence with outpatient counselling, and if they're not responding very well, step that up to a period of inpatient withdrawal or perhaps residential rehab. Somebody who was doing well in, say, day rehab, you may step them down to aftercare or ensure that they're linked to primary care. But we're also talking about horizontal integration, which is probably what people in the room at least do very well, being part of a community health service. But having the AOD specialist treatment at the centre of this sort of broader treatment system, but recognising that often because of the delay in help seeking, by the time clients do present, they're often experiencing quite marked chronicity and severity, and complexity in a number of areas, and therefore really do need linkage to things like mental health services, primary care, perhaps financial or legal counselling, support with their housing, employment, relationship or family counselling, and of course there'll be times when they need engagement with other healthcare services such as primary care and acute emergency services. So the overarching aim of the patient pathway study was to really get an understanding of, how can the system best be configured to optimise treatment outcomes. The specific research questions that we were aiming to address were, what is the impact of all these different types of treatment on substance use outcomes? What's the impact on other outcomes such as quality of life and functioning? And are there any particular combinations of AOD care and integration in horizontal and vertical integration that are particularly effective? Is there evidence that this continuity of AOD care is beneficial? And is there any evidence that engaging in this broader community horizontal integration is effective? So it was a prospective multi-site treatment outcome study. We recruited participants who'd been attending an AOD service for no more than 3 weeks. So that's not to say that was their first ever treatment episode, but that was a new episode, we call that throughout the rest of the data analysis the PIT, the primary index treatment. And we recruited participants from 21 different AOD services in Victoria and WA in 2012 to 2013, and they came from 37 different sites. That was 21 outpatient services, 8 inpatient withdrawal units, 6 resi rehab or TCs, and 2 supported accommodation sites, and they were collapsed in with the resi rehab and TCs for the subsequent analyses. In terms of inclusion criteria, these were kept intentionally broad or minimal, so we had obviously participants had to be 18 and above and to be able to understand English so that they could complete the measures. But really the only exclusion criteria was that they hadn't been in that primary index treatment for more than three weeks. And we had ethical approval from the relevant university ethics committees. The interviews, these were conducted by researchers face-to-face at the AOD services, and took about 90 minutes. I won't go through all of these today, but we looked at demographics, a whole range of substance use outcomes, well-being. We also looked at things like perceived social support, stigma and community support. But really the focus, I guess, was on substance use outcomes, quality of life, and this service utilisation. So looking at the breadth and extent of engagement with a whole range of health services in that year prior to the PIT, when they were recruited to the study, and in the year following recruitment. And we looked at things like which services they attended, who referred them there, when they attended and how many times. And then researchers did their best to contact as many as they could, 12 months later, over the phone mostly, and participants were reimbursed with a store voucher. So this is essentially the sample that we ended up with. So we had 1,054 participants who were screened or referred for participation. Unfortunately, 258 of those either failed the screen or were ineligible and didn't complete the baseline. So we had just under 800, 796, 214 from outpatient services, 352 from inpatient withdrawal, and 230 from resi rehab. And outpatient counselling, I mean, this was quite mixed. It was a combination of individual counselling, group counselling, pharmacotherapy, or some combination of those. And we managed to recontact 555, so 70% of this sample 12 months later. It was on average, I think, 380 days after that initial baseline interview. We were able to establish the outcomes of a further 3%, so 73% if we included those who'd sadly deceased or were incarcerated by that 12-month follow-up. So this is what the sample looked like. It was 62% male, the average age was 36, mostly Australian born, 7% of the sample identified as Aboriginal or Torres Strait Islander. 1 in 5 reported that they were either married or in a de facto relationship. Just under half had completed year 12 or a TAFE or an apprenticeship. Around a third said that they'd worked at least one day or been paid to work at least one day in the 90 days prior to the baseline interview. 84% reported that they were receiving benefits. Around a quarter had experienced some form of homelessness in the 3 months prior to the baseline interview. 30% reported that they were experiencing current legal issues, and just over half also reported that they had a chronic medical condition, and this was defined as a condition that requires medication or dietary restriction that has an impact on your activities, essentially. In terms of the sort of reasons they were seeking treatment, the most common presentation, again, as we expected, was alcohol. This accounted for 47% of the presentations. After that, it was amphetamines or methamphetamines at 20%, closely followed by opioids at 15% and cannabis at just under 15%, and only 3% of the sample were seeking treatment for other illicit drugs. So that was their primary drug of concern. However, just over half the sample had a secondary drug of concern other than tobacco, and around a third of the sample had a third drug of concern other than tobacco. And we actually didn't have measures of sort of diagnostic criteria. There was no sort of SCID, mini, CIDI, or nothing really assessing DSM or ICD criteria for substance use disorder. But everybody was seeking treatment, and the severity of dependence scales scores certainly suggest that they had high levels of dependence, a mean of 11 with nearly 90% scoring in the severely dependent range. Treatment goals were assessed at baseline. So for clients who identified alcohol as their primary drug of concern, I'm going to call them from now on alcohol clients, because to keep saying people who identified that as their primary drug of concern is 10 words. That makes the sentence very long and clumsy, so I hope I'm not offending anybody by using the term alcohol clients or amphetamine clients, but believe me, it makes for an easier listening or story, I guess. So in terms of treatment goals, 61% of alcohol clients said that they were aiming for complete abstinence. They wanted to stop drinking altogether. And around 30% said that they wanted to cut down on their drinking. For people who are seeking treatment for illicit drugs, then that was much higher. So 75% said they wanted to quit altogether, and only 15% reported that they wanted to cut down. This shows treatment engagement across the three primary sort of treatment settings. So between 63 and 86% completed that initial treatment, that primary index treatment. Highest rates observed in inpatient withdrawal, as you might expect, because it's generally a lot shorter, as we can see in the mean duration. So the average length of stay for those in an inpatient withdrawal as their primary index treatment was only 7 days, compared to 70 days in both outpatient setting and resi rehab. They were asked how satisfied they had been with that initial treatment episode, and these ranged from sort of just over 62% up to about 3/4. So moving on to actual outcomes then. So they were asked at 12 months, how many days in the past month have you used the drug, your primary drug of concern? That was really our primary outcome measure. 37.5% of the sample reported that they hadn't used that drug, that particular drug, in the month prior to interview, and 30% reported that they hadn't used any of those drugs that were concerning them on treatment entry in the past month. And perhaps not surprising, if we look at past literature, the highest rates of PDOC abstinence and all DOC abstinence were those who had resi rehab as their primary index treatment. And the outcomes for those in outpatient and acute withdrawal settings were pretty similar. And 14% reported that they had completely abstained from their primary drug of concern for the entire year, and not just that month prior to the follow-up. But if we assume that the people that we didn't manage to follow up had continued using their primary drug of concern, then a conservative estimate is that just over 1 in 4, 27%, were abstaining from their primary drug of concern, and around 1 in 5 all drugs of concern. And then if we look at how that differs by the drug of concern, this was surprising. We actually saw the highest rates observed among those seeking treatment for methamphetamine or amphetamine problems. So 61% reported they hadn't used methamphetamines in that month before the interview. And the rates of abstinence were lowest for alcohol clients, where only 28% said that they hadn't used. But this whole idea about, well, is that a meaningful outcome? Should we be aiming for abstinence? It's an ongoing debate, I think, after almost half a century of really scientifically robust, well-designed treatment outcome studies. We still can't seem to agree on what is a clinically meaningful outcome. What should we be measuring as an indication of treatment effectiveness? This whole idea of perhaps moving away from abstinence as a treatment goal or a focus really came around in the mid-70s. There was a study done in London where around 10% of people who had gone through alcohol treatment were found 7 to 10 years later to be drinking what they call innocuously, or drinking socially, but without alcohol problems. And that was later supported by a huge study in the US, the RAND Corporation, which had patients from 45 different treatment services, and again found that around 70% had significantly reduced their drinking, or they were drinking in a non-problematic way, and a very tiny percentage were completely abstinent at 18 months. So yeah, there's been this sort of gradual, I guess, shift or broadening to look beyond abstinence as the only treatment goal. And of course, clinician researchers like Mark and Linda Sabel in the mid-70s, they were suggesting that controlled drinking-oriented approaches were superior to abstinence-oriented approaches in terms of sort of well-being and functioning 24 months after being discharged from treatment. And it's really been in the last sort of 15, 20 years, I think, particularly in the US with clinical trials, when when they're trying pharmacotherapies and other psychosocial interventions, that there's been this adoption of things like heavy drinking days or time to relapse or percentage of abstinent days as kind of acceptable clinical trial endpoints. But there's never any agreement on just how much those particular parameters should reduce by. Of course, there's no indication of what they should reduce by for illicit drugs. But what we did is we adopted, there was a paper by Donovan and colleagues in 2012 which summarised the NIDA consensus on outcomes for alcohol trials, and this suggested that either abstinence or a reduction in the frequency of alcohol use by at least 50% is a meaningful outcome. So we lumped together the people that are in our patient pathways study that either achieved abstinence from their primary drug of concern or reduced the frequency with which they were using that by 50%, so in terms of the number of days, and we considered them to be a treatment success. I'm not entirely happy with the label treatment success because it implies anybody who didn't get that was a treatment failure, but essentially what we're saying is they responded positively to treatment, so bear with the label treatment success. And not surprisingly, we saw the highest rates of treatment success among those who had resi rehab as their primary index treatment, and otherwise were pretty similar in outpatient and inpatient withdrawal, outpatient counselling and inpatient withdrawal. We did see the highest rates of treatment success among methamphetamine clients. 3/4 were abstinent or significantly reducing how often they were using, 60% of opioids, 50% of cannabis, and just under 50% for alcohol. And again, if we take a more conservative approach and assume anybody we lost to follow-up did not achieve those outcomes, we're talking 1 in 3. We also looked at severity of dependence as an outcome measure. So here we're looking not just at whether there was a statistically significant reduction in their mean score, but also we accounted statistically for the kind of measurement error that you get from any test-retest when you re-administer a measure. And this indicated that there must be a reduction of 3 or more was a meaningful outcome. So what you'll see, the 43% you see there is actually the clients who either reduced their mean score, not their mean score, their score by 3, which was considered a clinically meaningful outcome, or they had a score at follow-up of less than 3, which is the cutoff for dependence across the different drugs of concern. So we're seeing a reduction in use and a reduction in the severity of dependence. Kind of it's mirroring what we've seen in MATES and ATOS. And then we looked at quality of life. The NIDA consensus panel also recommended that quality of life as an outcome measure. And in this study, the WHO breath was used. It's a WHO widely used WHO tool, and this essentially looks at well-being or functioning in 4 domains: physical, psychological, social, and environmental. And you can see that at baseline, on all 4 of these domains, the patient pathways clients were falling just below 1 standard deviation, below 1 standard deviation of population norms. But by follow-up, all of those were, the mean scores at least, were within 1 standard deviation of population norms. So there was a statistically significant improvement indicated by paired t-test. But and again, controlling for the sort of variability in the administration of that measure, taking all that into consideration, there was a significant and clinically meaningful improvement in all of those 4 domains. But this idea about quality of life and whether that's a meaningful outcome if we're not able to demonstrate that it relates to substance use it's an interesting debate that's happening at the moment. There was a really good article in probably last month's Addiction Now by Killock and colleagues, and that was essentially suggesting, if we can only say that it's either indirectly or potentially not directly related to substance use, then perhaps it's not what we should be measuring as an indicator of treatment effectiveness. So really what they've been able to show is that when you do see abstinence or reductions in substance use, typically we see very poor correlations between those reductions and the quality of life score. So rather than, I think what they're suggesting is rather than just ask about quality of life, we should be asking about negative consequences or making sure that when we're asking about quality of life and well-being, we relate it back to their substance use. So, for example, rather than saying how many days in the past 30 months, how many days in the last 30 have you been unable to work, we should be asking how many days in the last month have you been unable to work because of your substance use. And then we may start to see, a strong correlation or a greater connection between those two outcomes. And that's certainly something we're intending to explore in the patient pathways data. So do we see this pattern of improvement in quality of life among those who weren't able to abstain from their primary drug of concern or reduce their use by 50%? So that's something we'll look into and hopefully add to this debate. So we also looked at service use. This is, I guess, one of the main objectives of the study. We found that most clients had engaged in AOD services in the year before their primary index treatment. Most had gone on to engage further in AOD treatment. Most had, almost everybody had seen their GP, which is not unexpected, over that one year period. And around 3/4 had engaged in community services, excluding GP. But what we were most excited about finding was this, a significant reduction in ambulance attendances and hospital emergency department admissions in that year after engaging in AOD treatment. And this was also supported by the data linkage component of the study, where we were able to show that, particularly among those who had resi rehab, who had experience, and we were using ADIS data and hospital data, etc. And these weren't clients from the patient pathway survey, but we were able to demonstrate that an episode of resi rehab actually led to the greatest reductions in acute service use after engaging in treatment. So that was really encouraging, because obviously that will translate to huge economic savings. I thought this was published by Linda Behrens and Michael Savage in qualitative reports, but this is using data from the patient pathways cohort. And I don't think you can really read what the symbols mean, so I'll read those out. But I think it's a really useful way of visually representing the extent and breadth of essentially vertical and horizontal service use. So what you see here, the vertical lines represent the months leading up to the primary index treatment. So from 12 months all the way leading up to 0, which was the primary index treatment. The horizontal lines represent different clients. The colours represent the different types of services. So red are sort of acute health services, green social welfare type services, yellow justice services, blue AOD, and purple is mental health. And then the shape of the symbol is essentially the referral source, whether it was informal, GP, formal, or other. So what we can see here is, if we take the first one, which is participant number 16 as an example, we can see that in the month prior to engaging in that primary index treatment, this particular participant had 15 presentations to either ambulance, ED, or hospital inpatient admissions. And some of those were formal and some of those were informal referrals. But if we look back, we can see, at 7 months, 6 months, 5 months, there were opportunities where they were engaged in either AOD or social or welfare services or justice services, where perhaps, if there was integration between this, some of this could have been prevented. So that's why we really need to push for, I guess, resourcing for truly integrated care. And you can see in some of the other clients, there, it's quite engagement or engaged, disengaged, but quite sort of extensive engagement in these services before the index treatment. Okay, so we wanted to try and, as you can imagine, with all those different combinations, it was impossible to map out every single one and work out exactly which combination was the most effective. But we wanted to get a sort of a not rough and ready, but we wanted to get an overall picture, I guess. If we can define somehow these participants had some element of continuity or seamless care, at least in terms of specialist AOD treatment, and then there's some that engage and disengage and re-engage and disengage. So we the way in which we categorised the participants, if they subsequently had attended an AOD service and they'd been referred to that service by their primary index treatment or another AOD agency that they'd been involved with before, we considered that continuity of AOD care. If they had later attended an AOD service but it wasn't referred to, they weren't referred to that service by their PIT or another agency they'd been involved with, that was considered fragmented care and probably meant that maybe they continued using, disengaged from their treatment services and at some later stage re-engaged. So we had a group of continuity of care, that's actually spelled wrong, and fragmented care. You'd never have noticed that, I shouldn't have pointed that out, never mind. What we observed, which we were quite pleased to see, was there are significantly higher abstinence rates in the primary drug of concern among those who had continuity of care relative to those who had fragmented care, and we see significantly higher rates of either reducing or abstaining from their primary drug of concern if somebody has continuity of AOD care relative to fragmented care. And then I'll just share with you a quote we had from David, a 35-year-old who did one of the qualitative interviews about integrated working, and he said, "I found the system extremely effective with no overlaps. So you know what services are providing what, why and when, rather than having one service provide that when they can't necessarily. So it was helpful to make sure that my workers all know where I'm at. It's called transparency, I think. I need my psychiatrist to be able to talk to the drug worker, to be able to talk to my psychologist, for an example." So that's really just one, from the client's perspective of the sort of value in having integrated and horizontal working between AOD and non-AOD agencies. So I guess we really wanted to get a sense of, if we put all this together, if we put everything in the mix, what really matters in terms of achieving outcomes. If we consider the primary drug of concern, if we consider the primary index treatment, whether or not they had continuity of care or fragmented care, whether they engaged in community services, if we look at the effects of all those together in one model, essentially what matters. So first of all, if we take the whole sample, we found that if they were seeking treatment for methamphetamine relative to somebody seeking treatment from alcohol, they were twice as likely to be a treatment success. If they completed that initial primary index treatment, they were nearly twice as likely. So these are the odds ratios here in this logistic regression analysis. And if they attended mutual aid, the odds ratio there was 1.72, so 72% more likely to be a treatment success. And we saw similar predictors, significant predictors, when we were looking at abstaining from all drugs of concern. So being seeking treatment for methamphetamine. Here, this is PIT is withdrawal. So if their primary index treatment was inpatient withdrawal, they're actually less likely to be abstaining from all drugs of concern. That's below 1. So that means relative to resi rehab, they're less likely. And again, the significant predictors are PIT completed and attending mutual aid or peer support after that initial treatment episode. But what we were surprised by was that we found different predictors for clients seeking treatment for alcohol use disorders and clients seeking treatment for illicit drug use disorders. So we found that for alcohol clients, the only significant predictors were actually mutual aid attendance, so attending peer support. The odds ratio there nearly 2.5, so nearly 2.5 times as likely to be a treatment success if they attended mutual aid after that initial treatment episode, and if they engage in community services, so nearly twice as likely. It's 1.97 there. However, for illicit drugs, people seeking treatment for illicit drugs, it was 2.8 nearly for completing that primary index treatment. So for the illicit drug population in pathways, mutual aid and community services didn't predict outcomes. For them, it was completing that initial treatment episode and having continuity in AOD treatment. So we were quite surprised by those findings. And we explored a little further, we dug a little deeper with because we were surprised by the effect of mutual aid and peer support. So we looked at, because we had asked them how frequently they attended, so we looked to see if there's any relationship between the number of meetings that they attended, and there was a trend, a sort of linear-ish trend for, the more meetings they had attended over that 12-month period, the higher the probability or the rates of PDOC, abstinence, or reductions in use. Other functional outcomes that we looked at were employment. There wasn't a reduction. Around a third reported that they had at least 1 day's paid employment in the past 3 months of both baseline and follow-up. But we did see a significant reduction in the proportion who reported receiving financial benefits, a non-significant reduction in the proportion who reported experiencing homelessness, and a significant reduction in the proportion reporting that they were at risk of eviction. And finally, legal problems. So we looked at the whole, all different types of legal problems, and this reduced from 29 to 25% from baseline and follow-up. Everything from court orders, probation, parole, bail, sentencing, etc. And we did see, where there were reductions, these tended to be among clients seeking treatment for alcohol, cannabis use disorders. So in summary, what we know from the patient pathways cohort is that around half respond positively to treatment, and methamphetamine clients responded particularly well in this study. And around a third reported that they were abstinent from their primary drug of concern. We saw significant improvements in quality of life and related outcomes, a reduction in use of acute health services. We found that completing that initial treatment episode and having resi rehab as part of their treatment journey improved outcomes. And of course, we observed different pathways for people with alcohol versus an illicit drug as their primary drug of concern, whereby continuity in specialist AOD care and completing the PIT was really beneficial for people with illicit drug use disorders, or a primary problem with illicit drugs, and community service engagement and mutual aid was most important for alcohol clients. So, of course, every study has its limitations. There was no control group, so we can't say for that these outcomes can be solely attributed to the treatment they received. But we know from MATES and ATOS and hundreds of clinical trials that generally we do observe better outcomes from any treatment than no treatment. The sample wasn't representative of those seeking treatment in the AOD treatment system in Victoria and WA, but we did weight the data accordingly and we got the same results. We may have lost 1 or 2 significant findings, but they were still very much in those directions. So we're essentially saying, well, because we oversampled in residential settings, it's always easier to recruit when you have a captive audience. And despite the researchers' best efforts to try and get more people from community services, clients will come for their appointment and they've got stuff to do, they're in and out, and so it was really hard to get them to sit down and do a 90-minute interview. And also you get that sort of encouragement from clients in residential services for others to take part, so it's always easier to recruit there. But when we did weight the data by, so for every client we had from an outpatient service, they were, if you like, converted to represent, say, 7 people, because there's obviously much more people receiving outpatient counselling than resi rehab or inpatient withdrawal. And we got the results were maintained. We did lose 30%, and we did some analyses and found that those who were lost to follow-up were indeed more likely to be experiencing homelessness and legal problems at baseline, and they were younger as well, but this is inevitable. There can be very hard, very elusive population to try and get in touch with 12 months later. So, we had lots of what we hope sort of barriers to sort of mitigate against loss to follow-up, lots of secondary contact referral source, but 70% was really, when that sometimes involved up to 15 attempts to recontact someone, so that's as good as we could get. And of course it was self-report data. Most interviews were conducted over the phone, so no objective measures of substance use outcome, but we do know that there's strong evidence that self-report is reliable, is provided. There's been some conditions demonstrated that if you have those, then the data is generally reliable if confidentiality is guaranteed, and if the person doing the interview is independent to the treatment team, which was true in this case. So, lessons learned. I think there are a number of lessons that we've learned for a number of stakeholders, essentially. For service providers, we've seen clearly that completing that initial treatment episode is important. So we really need to think about how we can optimise treatment satisfaction, retention, to really build and maintain therapeutic rapport, which we know from several studies is one of the strongest predictors of engagement and retention. We need to think about offering enhanced case management or care and recovery coordination, and to make sure that they have access to a whole host of services in terms of vertical and horizontal integration, regular reviews and assertive referral to these wraparound services, and also particularly for alcohol clients to mutual aid and peer support as a free and widely available form of aftercare. For policymakers, I guess the lessons are, it really highlights the importance of funding models that promote continuity of care and integrated care, and the importance of having an adequately resourced AOD treatment system. Obviously, to really deliver high quality integrated working, we need highly skilled and trained workforce. Clinicians need access to professional development, supervision and mentorship to really deliver high quality care. For family members, carers and the community and people working in other health and welfare services, I think the messages or the lessons are really about needing to keep promoting this idea or this message or evidence that treatment works. I mean, as you would know as clinicians, to share stories of hope and transformation with family members and services, to keep aiming to increase the understanding that it requires a more sort of chronic care approach, like schizophrenia or diabetes or asthma, and to try and sort of counter this sort of prevailing pessimism that you often see in the media, and try and increase an understanding that there isn't a quick fix. It's not necessarily that 1 month in this rehab is what's needed, and to keep sharing knowledge that we do have really effective psychosocial interventions. We know CBT, motivational interviewing, ACT, contingency management, these work for many people, and we have great pharmacotherapies, but at least for heroin dependence. So we just need to make sure that this message keeps coming through. And for researchers, I think there was a lot we learned in terms of the challenges of doing treatment outcome studies, the methodological kind of considerations, but I think we also need to be a bit more sophisticated in our in capturing what is a clinically meaningful outcome for our clients, because we assume it's a reduction by this or a abstinence here, but we need to make sure that at the end of the day we're measuring the client's own goal from treatment. So I think there's room for improvement there. So I just said I'd mention a couple of examples of where it has led to changes in practice, or potentially led to changes in practice. But first of all, to flag that it takes time. The bench to bedside idea, it can take decades. We often hear that it's 15 to 20 years before a experimental drug reaches from the lab into your medicine cabinet. I think it's probably not too dissimilar for many sort of new social interventions or approaches. But it's interesting because in these different fields and using different endpoints and domains and different approaches, there seems to be a convergence in this estimate of the lag between health research and changes or implementation into practice being around 17 years. And so if that's true, then it's still early days, because the Patient Pathways report was published in 2015. We had papers that only really came out at the end of 2016 and last year. So hopefully there's a lot more to come. But we're often asked by CEOs and government officials and policy makers to provide evidence to be used in reports and inquiries and committees and conversations that essentially are advocating for better access to treatment or more funding. And I think this is recognising that it's a representative sample, it's a real world clinical treatment outcome study. So in the VADA state budget submission, there were two sort of excerpts from the Patient Pathways study or the report or the paper, which is essentially recognising the need to increase resi rehab and promoting investment in continuous care. And it's similarly in this report, the Parliamentary Joint Inquiry for Law Enforcement Inquiry into Crystal Methamphetamine final report also had some quotes and some figures from the Patient Pathways study, again recognising the importance of resi rehab, and again recognising the value of referral to mutual aid and the importance of reducing waiting time and increasing access, particularly in regional areas. And whilst, you know, we can only really talk about contribution and not attribution, as I said earlier, and I'd never be as bold as to say, because of the patient pathway study, this is what we've seen. But we have seen unprecedented expansion in funding and investment into funding in Victoria. So last year there was a 33% increase in amount of funding for the AOD sector. The ICE action plan announced 18 million for innovative models of rehab. So one of the recommendations from the Patient Pathways report, not surprisingly, was we do need to increase places for resi rehab, reduce waiting times, etc. But obviously that's really costly. And so at the time there were day rehabs were really starting to emerge, but they hadn't really been subjected to any evaluation. So that was a recommendation. And it's great to see that they're now rolling out day rehabilitation programs. But the drug rehab plan, which was released in October 2017, announced or committed to an investment of 87 million to expand services further, 100 new resi rehab beds, a new 28-day acute withdrawal and stabilisation programme for 100 complex patients a year, practical support and brokerage for clients and for their family members to really help them navigate their way through this what could be a very complicated AOD treatment system. And I'm really pleased to see that we've had a substantial investment in peer support capacity building in the sector that's largely been driven by SHARC in terms of peer support groups and family peer support groups. Okay. So these are some of the publications that have come out the Patient Pathways data set so far, but there are many more to come. Finding the time, as always. But if you'd like copies of any of these, please just give me a shout. I'll leave the last slide, have my details. But I wanted to acknowledge the Commonwealth Department of Health, who funded the study, and particularly the chief investigators in both the Turning Point and the NIDRI research team, and all the researchers that you see listed there who worked tirelessly to recruit and to try and follow up participants. But we're internally grateful for the generosity of the clients themselves who gave us their time, and the clinicians who really helped us get access to clients. And finally, thank you for listening. So there's my details. If you want any more information about the study or access to publications, please feel free to write to me or call. Thank you.
Another question. Are you aware of the Matrix program being used in Adelaide?
Yes.
Have you thought about using it?
Yes, definitely.
Can you explain what it is quickly to people who don't?
Can I explain to it?
Yeah.
Can I explain what it is? It's based on a model in the US. Rawson and colleagues developed this or evaluated this model, which is very intensive, and it's pretty much, it's an eclectic, well, my understanding of it, it's quite an eclectic approach. So it has a lot of group therapy, a bit of peer support, individual counselling. It sort of has principles of CBT and motivational interviewing, and it's quite intensive. And I am aware that the Adelaide group have piloted a program, and they've demonstrated that there's improvement in outcomes at the end of the program. But I guess what we're hoping to see is, after the program's finished, are those positive outcomes maintained? So we really do need more evaluation in these types of models, but that's a really promising one.
And there was just one clarification question around just confirming through your study, is it withdrawal management or detox kind of the least effective treatment?
Well, I mean, the least effective, if that's all somebody's getting, yeah. But we know that that's nothing new. I mean, it's not a treatment, it's just part of treatment. Yeah, but it was, I think it had the poorest outcomes. Fortunately, most people who had a period of inpatient withdrawal did go on to have something else, with outpatient counselling or some form of residential care. So, yeah. Matthew?
We have a question. Just 1 second.
Really great presentation, Victoria. Very important study there. Can you give us much of a sense of whether there was much variability amongst different services. So there were quite a few outpatient counselling services. Was there a lot of variance in outcomes there, and maybe features that were more indicative of better outcomes, more staff,
Yeah.
more staff, anything like that?
That's something we haven't actually looked at yet. It's a good question. I mean, there was, particularly in WA, and in Victoria as well, there were a number of regional services. So, yeah, I mean, there were, you know how it is when you start a study and you think, we're going to do a paper on this or a paper on that, and that was definitely something that we wanted to explore. Haven't got round to it yet, but I'm sure there would be. But when we sampled, we did tend to go for the larger services, yeah. Particularly if it meant researchers had to, you know, travel that distance. So we wanted to go to agencies that had, you know, a heavy throughput of clients. Yeah, but hopefully I'll have that answer for you one day. Be useful to know.
Thanks, Victoria. Are you guys following them up any further?
Love to, but we haven't managed to secure some funding to do that. So anybody's listening and they would love to find an 11-year, like ATOS, an 11-year outcome. We would love to do that, and we did seek consent from participants to recontact them, and quite a few agreed. It's still possible.
Just that John Kelly's group at Harvard did a big recovery study, and they found that the 5-year outcomes were much better than the 1-year outcomes, particularly for things like well-being and quality of life.
Yeah.
And if you think about it, it makes sense because in that first year where you kind of had some recovery, the reality of life hits you in terms of it's not just recovering from substance use, you've got to recover and functioning in every area practically. But normally after that 1-year period, they tended to be doing better because that other functional recovery was happening a bit more as well. So I guess it sort of makes a really strong argument for continuity of care.
Yeah, we'll use that argument in our next grant application. That's true.
We'll pass the hat around now, so if anyone wants to get a few dollars, get the follow-up study. I think that's it for questions. Please join me in thanking Dr. Victoria.
Thank you. Thanks for listening.